section, I can see there are a few soft tissue.
No, not here. So don't worry. There is nothing in the soft tissues in this case. This particular entity, how do you describe it? You know, what happens in neurofibromatosis? So that's why I've confirmed your diagnosis is correct, but you tell me why.
They get tibial bowing and pseudoarthrosis.
Yeah, very good. Pseudoarthrosis is a good answer. Why does pseudoarthrosis, why it is sort of in this particular case, it is quite pathognomic of pseudoarthrosis. There can be so many causes of pseudoarthrosis, but once you know whole of the history and everything else, then and look at the appearance. Okay, fine. Your third differential was NAI.
Mm.
Can you reconsider that? Why did you say NAI?
I just thought it was safe to say, given that there were fractures, and I should always have it at the back of my mind, even though it is unlikely that this
so
is.
NAI, where does NAI happen within the bones, I mean to say?
You get buccal handle fractures.
So metaphyseal, right?
Mm-hmm.
Okay, so let me first of all go through it, and then you will understand what happens. This case is an extremely important case because if you know it, you will immediately grab it. If you don't know it, it becomes a sort of a, absolute pain. Basically, in NF1, neurofibromatosis 1, this case can also come to you as a long case. In long cases, this might be a film, and with that, some other stigmata of NF1, maybe in a MR of the brain or something. And the unifying diagnosis will be NF1. So what happens is that these patients have got dysplasia of the bone, most commonly tibia, but other bones can be involved, long bones. Basically, clinically speaking, they might have a board type of appearance of a limb. It can be lower limb, it can be upper limb. Then what happens is, if you see this picture, that there might be thinning. There is a concept of bone resorption. And then when the bone is resorbed, we don't know why does it happen. There can be pseudo fractures or there can be true fractures. And what happens, if you see here, the case which you were seeing, there is a cupping, a pencil and cup type of deformity. And look at the edges become very sharp. So this is quite a pathognomic finding of pseudoarthrosis. We call it congenital pseudoarthrosis. And look at this picture here. And again, there is bone resorption. That is why it gives you this appearance. And look at this cupping. So this is NF1, pseudoarthrosis. NAI, please remember, NAI will have, metaphyseal fractures. Now, so as I've told you, that NF1 is a very, very important case, or very, very important, or very favorite of examiners, NF1, and multi-system type of cases they do come in the exam. So this is one of the plain film which can come with let's say an MR of the spine or MR of the brain, etc., with other stigmata. Okay, so this is your second case. This patient is a 9-year-old female, and the patient has presented with right foot pain. This is the left foot, this is the right foot. And this is the epifilm. There was nothing on the epifilm. So let me tell you that epifilm was not helpful in this case. So just concentrate on these laterals and try to see if there is a difference between left and right. Over to you, please.
So looking more closely at the left and right lateral foot x-rays, the most obvious abnormality I can see is there is a bony protrusion of the anterior talus, which is seen on the right foot but not seen on the left. I think this is a congenital variation, but I think it can be associated with pain.
So very good observations, well done. So let me elaborate for the audience that if you see here, this is the talus and this is the navicular, and this is the talus and this is the navicular, and this has been picked up here. Something is there, we call it talar beaking. Now your inference, candidate 16, is that there is some sort of congenital abnormality. What kind of congenital abnormality would be? So your thinking is very, very, absolutely spot on. But my question is very specific. What kind of congenital abnormality?
I thought it was the beaking, but is that seen with coalition?
Okay, very good, well done. So, what kind of view can help you further?
I would have wanted to see the AP in closer.
AP is normal, as I've shown you.
Okay.
AP was not helpful.
Perhaps have an oblique view.
Sorry, which view?
Would an oblique view help me?
Oblique view. Okay, well done. So here you are. And I will also show you. So your this is your left. This is so here. Let me correct myself. This is right here. This is left. This small view. Anything?
I'd want to look more closely to look at the talus and the Carcanial to see if they are separate or if there's evidence of coalition there.
Now, do you see any difference between here versus here? This is the calcaneum. This is the navicular. So there is a joint between here. And do you see a difference, this versus this? Agreed or not?
Agree.
And so you can see that this joint space, it gives you a slightly irregular type of margin. And if you see, look at the margin here, and this is very well defined. This is irregular, maybe a bit of sclerosis is there. What comes to your mind?
Carcano-navicular coalition, but fibrous, not bony.
Excellent, well done. Okay, so
hello?
We go back to the, hello, can you hear me, please?
Yeah, my internet just keeps on jumping a bit. What did you say? If we go back to the
I'm now summing up the case, so I'm not asking you a question. Your diagnosis is correct, okay? Now, collation-wise, this is again quite a favorite case for the examination. So remember a few basics. The most common collations are subtalar collation and calcaneo-navicular collation, both about equal percentage-wise. And there can be other type of collations, but they are not for the exam because they are more rare. Whenever collation occur, there are some indirect signs which you will pick up. So what happens is that the talonavicular joint, it becomes very rigid and it does not move normally. And because of that, there are abnormal stresses here and a bit of sort of a pseudo-osteophyte formation type of a picture where you get this talar beaking. So look for talar beaking, and in the exam, they are going to show you a lateral for that. So the eye sees what the mind knows. As soon as you pick this up and look at the age, they will be, young children, adolescent children, or young adults. Then your mind goes into, it can be either calcaneonavicular or subtalar. Point to remember is that calcaneonavicular is best seen on oblique view. AP view is useless. It is best seen on oblique view. And the subtalar one can be seen on an axial view. You know the DP view of the calcaneum. So I'll show you a case. So these views are very important for you to remember. I repeat, calcaneonavicular, oblique, subtalar, axial view. And this is what they are expecting for you to pick up. Another thing in the exam is they might show you only one side. And a leading question by the examiner will be, what will you do next? And the answer is, I will do the X-ray of the other foot also. Why? Up to 20 to 25, some people think 35% cases are bilateral. This is a leading exam question. What will you do next? I will do the other foot also. And if they want, they might show you the other foot. Now, with that background, look at the concept. The concept is that collation can be fibrous, it can be cartilaginous, and it can be bony. So bony means there is a bony bar. When there is cartilaginous or fibrous collation, then you will see some changes around in the bone. Sclerosis, some the joint space might be reduced and things like that. But you will not find a bony bar. MR is considered very sensitive there. But in many cases, you might actually CT, some people think might be a savior. Having said that, usually in an FRCR exam, they go for plain films. So let me show you a few more examples. So this was calcaneonavicular collation. Well done. So still with you, candidate 16, this is again your case.
So again, there is left anterior talar beaking.
Excellent. So because you are doing collation, so you asked for AP film, you asked for oblique film, and there was nothing. What else will you ask then?
Where else for the axial to look for subtalar?
This is the axial. So let me give you a hint. This is the normal side. This is the abnormal.
Okay. Sorry, which one is abnormal?
Can you see my mouse?
The red cursor.
Laser. So this is the abnormal.
Okay.
I think your annotation function maybe is working if you can switch that off.
I can't see it.
You cannot see it.
I don't know.
Fine. That is a good answer. Let me go back to the basics. Look at this. This is your calcaneum. Calcaneum. Now, one of the landmark is this aspect, which is known as the sustentaculum tali, which projects medially. Now, calcaneum has got three facets, and this is the anterior articular facet, this is the middle, and this is the posterior. The posterior is the largest, middle is overlying the sustentaculum tali, and this is the anterior. This is where the action is. So, middle, you have to remember for the exam. And though it can happen in the posterior also. Now, your normal anatomy is that this is the sustentaculum tali. This joint here is the middle joint, right? And look at this middle joint, and you will agree that there is irregularity. Look at the joint space. The joint space is reduced, irregular. Look at the marginal sclerosis. So indirectly, there is a collation, but this collation is not bony. So this is subpellar collation. Okay, because of film factor, I will just describe the film and ask you a leading question. You can on this. There is a color beacon, and what else? There is a sign there, and this time the collation can be diagnosed just from this X-ray.
So there's a bony bar between the talus and the navicular bone, and loss of joint space.
Bony bar is not very convincing. It's overlapping. No. A bit of stretch of imagination. There is a sign there. I want to hear the name. Do you see this thing?
Oh, the sustentacular tali?
No, this sign is known as C sign. So what happens is, this will be, if you go back just to refresh your anatomy, go to lateral, and this is how it projects, right? This projects. This thing becomes very, very dense and prominent, right? So this is a normal type of an appearance, but then it becomes abnormally dense and very well defined. So, and with this is quite pathognomic of what we call, a frank collation. And this time, what is happening? That there is a what we call a bony bar at the same joint, the middle subpellar joint, and this is how it projects on a lateral. This is a CT scan. And MR. This is another case, by the way, and you can see this bony bar on an MR also. Okay, this is just to show you the same thing on CT scan. So right, left, right, left, right, left, right, left, right, left, right, left. The abnormality is on the left side. You tell me which joints are involved. Remember, anterior, middle, and posterior.
The middle articular surface is...
Okay, so if you see here, this is the, and here you can appreciate that there is no bony bar, but the joint space is reduced. There is sclerosis. What about the posterior?
The posterior is the largest. The posterior looks preserved.
If you see here,
reduced, okay.
Yeah, reduced, right? This is the level of the fibula. So the point is that posterior as well as this one. So this was a coronal view of the anterior facet, the middle facet, and the posterior facet. Some of the other you are getting feet and feet. So what is your diagnosis? Spot diagnosis. 5-second diagnosis.
Are they missing their... They've got rocker bottom feet?
Excellent, well done. And what do you mean by rocker bottom feet?
It just appears... So like the talus looks very what's that word? The talus has an abnormal configuration.
Yeah, excellent. So rocker bottom foot is basically a vertical talus, right?
Mm-hmm.
The configuration which you are talking about is a vertical talus. And interestingly, as I've told you that these are the type of cases which have come in the exam, and only about 2 exams ago somebody got it. I never used to teach rocker bottom foot to my students because I thought that this is too specialized or whatever. But it was asked in the exam. And basically in rocker bottom foot, what happens is vertical talus means that technically there will be a talonavicular dislocation. Even if navicular is not ossified, you cannot see it, you can infer that it will be out of socket. There are a few lines which are given here. The mid-talar line should pass through the base of first metatarsal, the mid-calcaneal line, base of fourth metatarsals, and they are not seen. In an exam case, I don't think so. You should go for lines. It is obvious that this is more vertical. It should have been like this, right? So rocker bottom foot can also be seen in acquired conditions. You just name this. What is this? Candidate 16, question for you. This is 7-year-old, and this is rocker bottom foot as an acquired condition. What is it?
There's destruction. There's bony destruction of the anterior talus.
Mm-hmm.
As well as the metatarsal bones as well.
So your diagnosis?
My diagnosis, Charcot foot.
Excellent. So this is Charcot joint, classical. We will cover it in our 4th chapter. But here what happens is that this is a diabetic foot where there is bony destruction. Look at the density, which is increased. And if the inference is that there has to be because the navicular is destroyed, there is a dislocation there. And you can see that rocker bottom effect. Okay, now is a time for a 5-minute break. We go. The next candidate is number 13. Can number 13 unmute?
Hello, hello, children. Can you hear me?
Yes. So this is number 13, correct?
Yes.
Okay, so I will now go to you.
Okay, this is a frontal radiograph of the skull of a 1-year-old male, showing increased bone density of both.
Don't worry about bone density. That is
Right.
just. Please continue.
Right. I think there is thickening of the skull bones, or is it projectional?
Thickening of what?
Thickening of the skull table, or is it projectional?
No, forget about it.
All right. I'm looking at the clavicles.
Excellent.
They seem to be not well formed.
Very good.
So my differential diagnosis could be Cleidocranial dysostosis. I'm searching for any Wormian bones, but I cannot see this clearly. There is a differential diagnosis for hypoplastic or dysplastic clavicles. I really don't remember, I only remember the Cleidocranial dysostosis.
Okay. Okay, well done.
Right,
okay, so if you see here, I can ask you, okay, before I take over, let me ask you another question. What is, other than cleidocranial dysplasia, anything else in the congenital world which you will consider in the differential?
Yeah, the chest wall seems abnormal too.
I'm question, but I was saying anything else in the differential diagnosis from congenital world.
I don't have anything on mind.
Right. Okay. So if you see here, in this particular case, look at the clavicle, and part of the clavicle is not well formed, and part of it is hypoplastic. With that, even the scapula, particularly look at the glenoid, and they are small. If you look at the skull, these are Wormian bones. You see this fontanelle is open. For a 1-year-old, this is too much. It should have been, close to just, should I say, this is 1 year. And then if you see here, these are Wormian bones. Wormian bones are bones which are within the suture. Key in this case is to comment on the mandible. And that is a key exam point. And I will tell you why. Now, if you see the film of the rest of the abdomen and pelvis, first thing which comes to the mind is that look at the pubic symphysis, and there is widening of pubic symphysis. Even look at the posterior elements of the vertebra. So this is the vertebral body, and this is not joint. And look at the rib, and these are short ribs. But these are all, subtle findings. The main findings is this one. So now comes the art of differential diagnosis. The first diagnosis is, in your Chapman, this is 1.28, page 27 in the new edition. Erosion or absence of the outer end of clavicle. And these are the most common causes, which we will see examples of later on. But in the less common, you can see this cleidocranial dysplasia, and second thing is pycnodysostosis. So please remember, these two are asked in the exam because both of them are congenital. hyperpara, rheumatoid, all of these things are very, very important. But in this world, these two are critical: cleidocranial dysplasia and pycnodysostosis. So, how do you differentiate between the two? There are things which, and there are some discriminators which I am going to teach you. Another differential diagnosis in which both of them go together is widening of symphysis pubis. And even here you can see cleidocranial dysplasia, pycnodysostosis. Basic pathology in cleidocranial dysplasia is that there is poor ossification of cartilage. The membranous ossification of bone is deficient. So that is the difference. Now, this is another example where it's a 14-year-old, but if you get this film, you start describing things, but then you understand that there is no clavicle. Clavicles are missing. Look at the glenoid, and the glenoid is sort of small. And this is rest of the findings of cleidocranial dysplasia. Now, look at the Vermian bones. Vermian bones are bones within the sutures. For example, this one is a Vermian bone. The key finding, look at the pubic symphysis, poorly ossified. The key finding is this thing, mandible. The mandible is normal. And why is it important? It is a discriminator, one of the discriminator to discriminate it from pycnodysostosis. If you see the maxilla, it is small, but mandible is normal. And there is an angle of mandible. So this is the main difference. And there is another difference which I am going to highlight. So now, candidate 13, if you can tackle this film.
Yes. Okay. So these are frontal and lateral.
So let me tell you that this is pycnodysostosis, right? You tell why is this pycnodysostosis?
First of all, there is no angle of the mandible.
Okay.
And I can see Vermian bone in the lambdoid suture.
Okay. Anything else?
No, not to my eyes.
Okay. I of course, because of projection, it might not be visible to you, but look at the bone density. There is a bit of sclerosis. But
Yes.
if you look here at the base of the skull, and you will appreciate there is a bit of sclerosis. Look at the orbital margins, and they are all sclerosed. Bone density in the exam is always slightly, difficult to pick up at times because of projection, but the examiners are going to help you. So if you say that there is increased bone density and they tell you don't worry, then fine. Otherwise, they might help you. So the key thing here is in that there is increased bone density. And otherwise, quite a few common things happen in pycnodysostosis, and that's why you can confuse it with cleidocranial dysplasia. I will come back to this film, but can you describe it for me? What are the findings?
Okay, so there is increased or diffuse bone sclerosis. There is also negative ulnar variance. There is short force metacarpals.
What's happening to the distal tufts here?
Yeah, acroosteolysis.
Acroosteolysis, right. So now in pycnodysostosis also, clavicles can be absent, or part of the clavicles can be absent. There can be Vermian bones and things like that. Acroosteolysis can be there. In cleidocranial, usually there is no acroosteolysis. Key discriminator between the two is mandible. Mandible will be small and obtuse in cleidocranial dysplasia. And another finding is that bone sclerosis. So in pycnodysostosis, there will be bone density will be increased. This concept is extremely important for you to remember. If you go back to the metabolism of bone, we know that there is a concept of what we call the concept of bone. There are osteoblasts and there are osteoclasts. So bone remodeling. Osteoblasts, they produce bone, and the osteoclasts, they then remodel it. When osteoclasts have got some issues, maybe in number or their, you can get bony dysplasias in which there is sclerosis of bone. And this is a spectrum of conditions, and the spectrum can be from extremely, whole of the bone skeleton will be high density versus slightly less versus more lesser, and lesser. And this is exam case, this is exam case, this is for differential diagnosis, otherwise no, this is exam case, and this is exam case. All of them are exam cases in which there is a spectrum of sclerotic bony dysplasia. So in pycnodysostosis, this is what can happen. If you see the medullary cavities, you will see that they are encroached and they are not very well seen. So this was pycnodysostosis. In your book, there are causes of generalized increased bone density in a child. Extremely important differential diagnosis. But in dysplasia, you can see the names which I have told you. I have not told you this one, but otherwise osteoporosis, pycnodysostosis, Engelmann's disease, Mallory-Ostosis, these ones you have to remember. And please remember, for ST1s, gradually as you go through the whole curriculum, you have to then learn what will happen here, and you have to then learn what will happen in the poisoning, etc. And so finally, 2 years down the road, you might be able to discuss on a particular case what is the cause of increased bone density. And similarly, in adults, generalized increased bone density, it becomes slightly different. But please remember, a patient who has got pycnodysostosis as a child will become an adult, right? With pycnodysostosis. So these conditions which happen in onset in pediatric group ultimately might be seen in an adult age group also. Another differential diagnosis in your book is about distal phalangeal destruction, and out of the less common cause, pycnodysostosis is given there. Okay. Please, can you tackle this case?
Hello, yes. Okay, this is a frontal radiograph of the skull. There is abnormal shape of the skull vault. Maybe it's taking trichocephaly or towering of the skull. The clavicles are normal in shape. I can't really appreciate the rami of the mandible very well, but maybe it's just an over-penetrated film.
Yeah, don't worry about mandible.
Yeah.
So, if you see here, this is portion of the temporal bone, how it is bulging, and something is projecting here. I will show you lateral. And now concentrate on this area, and can you reach a diagnosis?
Okay, so there is the petrous bone is supposed to be dense. I think this density is maybe
The cervical spine.
yes. Not really sure what's happening.
Right. And this is osteogenesis imperfecta. In Scottish literature, Demoshunter skull, this is that cap. Actually, also in literature, you will see this word floppy hat sign for this. Actually, if you see here what is happening, let me explain to you. First of all, look here. This is C1, this is the dens of C2, and this is the foramen magnum, this is the clivus. Now, if you draw a line from this point, which is the posterior inner border of foramen magnum, you draw a line towards the heart palate here. And this tip of dens should not be for more than 4.5 millimeter superior to that. And when it is more than that, we call it basilar invagination. Now, basilar invagination can have various kinds of causes, congenital as well as acquired. If you just remember it, that basically the bone is not normal. It is, just remember it like that it is soft bone. And invagination means that the cervical spine goes into the foramen magnum. So this is what happens in osteogenesis imperfecta. This will also happen in these conditions like Paget's disease, hyperparathyroidism, osteomalacia, rickets. In rheumatoid arthritis, it happens because of subluxation at the atlantoaxial, occipital joint, which I will show you when we reach rheumatoid arthritis. But having said that, this is a very, very good case. And please remember, if you see it once, you will know it. Otherwise, you are going to miss it. You have to stretch your imagination here because the dens is not very well seen. But where is the dens? And, this was the line of the heart palate. And you can imagine it has gone in. So this bulges out the temporal bone and the occipital bone, giving you this Demoshunter skull or a floppy hat sign, whatever you want to call it. Yes, please.
Okay, so there is a generalized increase in the bone density, giving a picture frame appearance involving all the radiographed bones. The differential diagnosis is osteopetrosis, which is marble bone disease, maybe myelofibrosis. If the patient is a child, I'm more inclined to the marble bone disease.
Why is it a child and why is it not a child and why will it not matter? Osteopetrosis can happen to a child who becomes an adult, isn't it?
Yes, if it's like a mild form, yes.
So the point is that is there some specific sign here where you can say that this is osteopetrosis?
This picture frame of the vertebra.
Okay. Anything else?
I can see some soft tissue calcifications over the left upper quadrant.
Okay, no, I'm not interested there. Anything else? Right. So let me take over.
All right.
Basically, this is osteopetrosis, and why is it osteopetrosis? Please remember that osteopetrosis is what we call the sclerotic bony dysplasia, which is of most significant magnitude. And osteopetrosis has got a cyclic type of pattern. So cyclic pattern means that there are cycles where normal bone deposition is there, and then there will be more sclerotic bone deposition, and it goes into cycles. People don't know why it happens like this. But this particular sign gives you some leeway to diagnose it. The cyclic pattern will give you normal bone density versus sclerotic bone density at particular parts of anatomy. You will get this bone within bone appearance in the vertebrae like this. You can get lucencies at the metaphyses, which are perpendicular to the long axis of metaphysis. And in the diaphysis, not in this particular case, it's not visible. You can get lucencies which are along the longitudinal axis. But at the iliac wings, you will get this arcuate type of, lucencies or bone within bone appearance, bone and within bone appearance. This is considered quite specific for osteopetrosis. Now, again, a repetition of generalized increased bone densities in children and adults. This is the bone within bone appearance differential diagnosis, 14.14. This is another case of osteopetrosis. Can you just describe to me how will you describe this thing, Tumor?
It's flask shaped.
Excellent. So this flask shape means that there is an issue with modeling of the femur, remodeling. And there is a bit of a differential diagnosis for this, Erlen-Meyer flask deformity. And you have to remember these because they can also come in the exam. Osteopetrosis is one of them. Thalassemia, gouters, and lead poisoning are the others. Okay, now this is a very important case for the exam. It has come quite a few times.
Yes, I think it's malariostenosis.
Can you describe it for me?
Yes, there is not diffuse, like thickening of the cortex of the femur and tibia on the right side, I assume. And it's just candle, like molten candle, dropping wax, candle wax on the bony cortex. This is how it's classically described. Can you hear me?
I can hear you. You've done well. Okay. So let me describe malariostenosis and what happens there. Basically, please remember that it is one of the sclerotic bony dysplasia. So the osteoclasts are not working normal. And there will be deposition of bone both on the periosteal as well as end-osteal surface of the bone. So this is the periosteal surface. This is the end-osteal. ST1, this vocabulary, you have to develop this end-osteal means inner side, right? This is the medullary cavity. And in a long bone, it goes along the shaft to give you this molten wax type of and classical appearance. If you look at this case, look at the tibia, and again you can see this particular type of pattern. So this is malariostenosis, and I will show you a few further cases here. as an examples. And so this is in hand, and this is in clavicle here. This is in first metatarsal here. So if you know it, very simple. Otherwise, you will be always struggling about it. Now, this particular case I have kept for differential diagnosis. Can you please tell me what, there is a bit of sclerosis, but anatomically speaking, can you describe it for us? Where is it?
Okay. So it's right here.
Excellent. So if you look carefully, this is the epiphysis, this is maybe the metaphysis. It is normal, but there is sclerosis. And just like the previous case, but it's more bilateral symmetrical. Same thing happening in tibia, same thing happening in fibula. And if you go to the other side, this is the right and this is the left. And you can see the same thing. This is for the differential of sclerotic bony dysplasia. And this is what we call Engelmann's disease, diaphyseal dysplasia. If you remember diaphyseal dysplasia, automatically it tells you what it is. This is your last case.
Yeah, this is spot on osteoporosis, multiple.
Osteoporosis is a simple case, but of course it becomes simple once you know it. Basically, osteoporosis, pathologically speaking, is just like multiple bone gaps. And these are round joints usually. So if you see here, they can be lanceolate or oval or rounded. They are usually around big joints on both sides. Just like this case, this is quite classical. And this is known as osteoporosis. Not to be confused with anything more sinister. Okay, thank you very much.
Thank you.
So next is number 15. If you are hearing me, if you can unmute yourself.
Yep, hearing loud and clear.
Okay, so yes, please, over to you.
This is a frontal pelvic radiograph of a child. The striking abnormality is located at the intertrochanteric region of the right proximal femur, where there is a lesion within the bone centered in the medullary cavity that has a thick sclerotic border, but is generally lucent with a ground glass matrix. I think reversing this lesion, which I would be specifically concerned about if the patient's presented with pain. In terms of the likely etiology, I think it has appearances consistent with fibrous dysplasia, in which case I would like to assess whether there were clinical reasons to suspect polyostotic disease and image other areas of the skeleton accordingly.
Okay, excellent, well done. So if you see here, in this case, what is happening is that there is a lesion, and this lesion has got particular configuration. There, by the way, is C part of the lesion has got ground glass type of an appearance. On one of the pathognomic can everybody mute themselves, please? If there is a pathognomic finding is this sclerotic rim around the lesion, and If you look at CT, this is very good for learning what is happening inside. What is happening inside is that you have got some matrix which is slightly what we call ground glass type of matrix, and then there are some cystic spaces also. Surrounding that is a thick rim of ossification or calcification. This thick rim is known as the rind of orange appearance, and it is considered absolutely pathognomic of fibrous dysplasia. Nothing else will give you this kind of thick rim. So let's go back to the basics and consider the various kinds of, the concepts of fibrous dysplasia and what kind of films can come in the exam. It is one of the most favorite pathologies to be shown in the exam. And even it is shown in head and neck, for example, or skull and CNS. And if you know the pathology, you can make your radiology. What I've seen is that inexperienced people, they think that fibrous dysplasia means ground glass. No, fibrous dysplasia can be ground glass, but can be other kinds of appearances. So we have to go back to the pathology. First of all, look at the word ground glass. And this is from Wikipedia. Ground glass is a glass whose surface has been ground to produce a flat but rough matte finish. So this is the appearance. It is a sort of an opaque type of a glass. This is known as ground glass appearance, classically seen here. But let's go back to the pathology. Actually, what happens, it is a dysplasia. So there is a concept of monoostotic versus polyostotic. Monoostotic means only one bone is involved. In polyostotic, there are patients in which more than 80-90% of the skeleton might be involved, but it is never symmetrical. Polyostotic fibrous dysplasia occurs much earlier age, maybe in the first decade, and fibrous dysplasia presents in otherwise in second or third decade. Its presentation is young. In polyostotic fibrous dysplasia, one thing which is very important to remember is that the facial skeleton, particularly the maxilla, mandible, these can be quite commonly involved. Base of skull can also be involved. Now, pathologically speaking, so if you know the pathology, you can make the radiology. Basically, what is happening in fibrous dysplasia is that there is fibrous tissue as well as cysts within the medullary. Let's consider the medullary cavity, within the medullary cavity. Now, then what happens is these cysts, some of them have got blood and some of them might not have blood. Irrelevant, because what happens is that this fibrous tissue starts ossifying to a various degree. And at a particular, if it ossifies to a particular degree, it might give you a fibrous type of, a ground glass type of an appearance. So take home point is that fibrous dysplasia can be lytic, can be ground glass, and can also be sclerotic. Many a times it has got a mixed picture. Don't get confused. And within a long bone, the location is metadiaphysis, just like this example. So polyostotic fibrous dysplasias are always confused. If you don't know it, in the exam, you will confuse it. Look at this case. This is a beautiful case where what is happening, look at this metatarsal, metacarpal, and you can see that the medullary cavity is obliterated. You don't see the medullary cavity, it is obliterated, and then there is this ground glass. Some lucencies are there, some, and then there is a lytic lesion here in the distal. This should not confuse you. If you don't know that fibrous dysplasia can have lytic appearance also, you will always confuse this. So that is why I say know the pathology and make your radiology. So I'll show you many examples of fibrous dysplasia just to show you various kinds of presentations of the same condition. Another case of fibrous dysplasia, and the pathognomic finding is the rind of orange appearance. If you see it, just call it. There is nothing else which will give you this kind of appearance. Okay, candidate 15, can you describe it for us? We know it is fibrous dysplasia, but I want to see your description. So I'm going to give you your description.
So this is a focused radiograph frontal of the right hip and proximal femur of a child. There is a bony dysplasia with abnormal contour to the proximal femur where there is coxa valga, and the entire epiphysis, metaphysis, and most of the visualized diaphysis have a thin cortex with a ground glass matrix. There's evidence of probably previous fracture, most notably at approximately the junction of the proximal third and distal 2/3 of the diaphysis. And I think the visualized pelvis also looks abnormal. Therefore, I suspect that the skeletal dysplasia that is demonstrated here is polyostotic.
Mm-hmm.
Other than that, I think there's also some periosteal reaction evident at the lateral border of the femur.
Right. What is this? What is this? What is this?
So I think that's new bone formation, essentially. So the lower down, it looks like there's been probably a pathological fracture, which is sort of amalgamated with a...
Is it healed?
It's healed, yeah.
Right. Okay, I'll take over. Now,
Okay.
This is a film. In FRCR world, we call it a story film. It is telling you a story. What is the story? The story is, first of all, you have picked up the finding that, loss of medullary cavity, ground glass appearance. This kind of, this is known as a shepherd crook appearance. With that, you can infer what has happened, that in the past there must have been a fracture here, and you can see that there must be a plate here and there must be screws here. So this is all, the story is that there was a point when there must be some internal fixation here. So, so this is whatever has happened in the past. But what I wanted to highlight is this kind of cases which can come in FRCR, we call it story case. It tells you a story. I'll just skip through these. I want to show these just as examples, just to develop your eyes. And there are many examples which I'm going to show you, but we don't have time to tackle each and every case. But if you see here, a 34-year-old, there is a lucent lesion with a bit of marginal sclerosis. This marginal sclerosis is a very good sign that it is not very aggressive. Please remember, in the pelvis, usually fibrous dysplasia will be more lucent. Don't expect a ground glass appearance. Then there is something else here. You see this thing? This is the second lesion. And then there is a third lesion here in the femur. If you see the CT, just to develop your eyes, look at this appearance. So this is that lytic type of appearance surrounding sclerosis. And then this is that lesion which was on the acetabulum. And this is the lesion which is at the neck of the femur. So this is also polyostotic fibrous dysplasia. Another case, which is, can you please tackle this one? You know that it is fibrous dysplasia. I want you to describe it for us.
Okay, so I'm presented with a radiograph of a 25-year-old female patient, specifically looking at the bony abnormality. I think that's referring to an expansile lesion of the lateral right fifth rib. So as I mentioned, there's bony expansion, but it has well-defined borders, and actually looks predominantly sclerotic, but I think partly that's due to the fact that it's on fast to the X-ray beam. It's difficult to describe its internal matrix, although it looks quite uniform.
Right.
Oh no, sorry, I'm looking at the wrong thing. Okay, no, so it looks lytic. It looks lytic with thinned cortices, well-defined borders, no bony destruction, and mild expansion.
Right. So there is a bit of expansion, and with that expansion, there is no destruction. So it doesn't give you that, because expansion with destruction means something else, and without destruction means something else. Usually malignant lesions will not expand something like this. They will just destroy it before expansion. So now, if you see here, focal rib lesions, solitary or multiple, this is from your book, and they can, of course, occur in both adults, as in fibrous dysplasias here, and they can occur in the child. Common sense, it is just age of presentation. Fibrous dysplasias here. This is an example. If I report this CT, I will never be very confident in calling this as fibrous dysplasia. But the point is that there are some, if you start thinking in detail, what can it be? So, 42-year-old, not a very old patient, very expansile lesion. Again, the cortex is not destroyed. Within it, there are these lucencies, etc. This is not classical ground glass. But go back to the basics, and please remember that fibrous dysplasia can have cysts, and it can be lucent also. So I'm not saying that you can diagnose it, but this kind of a case, the examiner is going to ask your thinking, and the examiner knows that you might not be able to diagnose it. At least you can think aloud and tell them what you are thinking. Yes, please.
So this is an angled facial bone view skull radiograph in which the obvious abnormality is obscuration of the right maxillary sinus with bony expansion that has a uniform ground glass matrix. This is consistent with fibrous dysplasia. There's no bony destruction and no cortical loss.
Okay, very good. So basically, if I show you the CT of this patient, which is, what is happening now, this is the zygomatic bone, and there is a fibrous dysplasia, and this one is classical ground glass. It is encroaching the sinus here, and similarly, it is encroaching the sinus here, and you can see this thing is encroaching the sinus here. So if you are not very careful, you will say that this is sinusitis. No, this is not sinusitis. Actually, this is bone which is giving you this appearance. And fibrous dysplasia in head and neck, it comes quite often. And remember that, the appearance can be mixed. It can be ground glass, and it can be lytic also. So fibrous dysplasia, now I'm showing you another case of polyostotic fibrous dysplasia. As I told you that in some patients, close to 80-90% of the skeleton might be fibrous dysplasia. This is, look at this limb, everything is abnormal. And then you see a bit of ground glass, etc. This is one example. And this one is another very, very good example. I showed you this phalanx as a just this one as a crop image, but you can see, look at this ground glass, and what students, they do at times confuse, why is this lucency there? Why is this lucency? It is the same thing, and this lucency can happen in fibrous dysplasia. This is another CT scan, fibrous dysplasia of the zygoma. And look at this one. This is fibrous dysplasia, partly sclerotic and partly lipid. So this should not worry you. Look here. How do you differentiate between Paget's disease and fibrous dysplasia is something for the exam. So one discriminator is age. Paget's disease is old age group, and fibrous dysplasia is young. Second thing is which bones are involved. Paget's disease, classical calvarium, as in the skull wall and temporal bone also. And fibrous dysplasia, the maxilla and anterior base of skull and the mandible. So these are the two parameters. There is a type of fibrous dysplasia, radiological, which we call Page-Dwight type of fibrous dysplasia, in which there are sclerotic as well as lucencies, and this will be difficult. Just on the basis of radiological factors, it will be difficult because it's not classical ground glass. Okay, this is a very, very good case. Over to you. Classical exam case.
So I have selected axial reconstructions from a CT scan of the base of skull with both soft tissue and bone windowing. There's a diffuse bony abnormality centered around the left anterior and middle cranial fossas, which specifically in the region of the left sphenoid wing has bony expansion with a fibrous matrix. But I'm also looking on the right side where there is an abnormality around the body of the pterygoid and the pterygoid plates, which are not very visible and look like they might be eroded. My concern being that although the appearances are of fibrous dysplasia, I wonder if there could be some malignant transformation.
Excellent. Okay. So if you see here, classical fibrous dysplasia base of skull, but on there is bony destruction. The pterygoids are gone. The walls of the paranasal sinus, the maxillary sinus, they are also gone. So this is malignant transformation, and this can happen in about 1% of cases. Can you tackle this one?
So I've got a static image from what appears to be a technetium 99 bone scan of the whole body of a skeletally immature patient. There are numerous foci of increased uptake, most notably at the left humeral diaphysis, the left hemipelvis, left proximal femur, left proximal and mid femur, but also at the physes surrounding the knee joint bilaterally. I think that this indicates increased bone turnover at those sites. The physeal increased activity might be physiological, although it does look quite prominent and is not matched at some of the other sites of growth. So I think that probably is abnormal. And that might indicate a metabolic component or poisoning, for example, fluorosis or lead. But then there are also there's also abnormal tracer, as I mentioned, in the left humerus and the left femur. And I'm not sure how to explain both together. Perhaps there are fractures due to some disorder of bone metabolism.
What will you ask for?
I'd ask for plain radiographs, specifically.
That's very good, because that was what I was looking for. Please remember, in the exam, whenever you get a nuclear scan, you must ask for what we call plain film for correlation, and don't just report it per se. This is polyostotic fibrous dysplasia, and polyostotic fibrous dysplasia comes in the exam so often on nuclear medicine, even PET scan, bone scan, both, SPECT, everything, fibrous. Please keep your minds open. So I don't know much about nuclear scan, but I'm just showing you because it does come. We have got a dedicated nuclear medicine A to Z course. So here, please remember that fibrous dysplasias, when it is active form, radiologically speaking, will be lytic with a bit of ground glass, but complete ground glass will not be active. It will show uptake. This is from Indian Journal of Nuclear Medicine. This is a case example which this patient presented at the age of 32 years with fractured femur, and a bone scan then showed multiple lesions. And look at this lesion here, and look at this one. And this is the rib, which is fibrous dysplasia at the base of the skull. Again, this is a SPECT, nuclear scan, which has got uptake there. This sign in literature is known as pirate sign. You can make out a pirate, you see this. So pirate sign. So this is sphenoid wing. And this is again from literature, from Mayo Clinic. And this patient is interesting, where this is a PET scan, by the way, where the patient has a known breast cancer, and they were worried about what's happening in the spine, and ultimately it showed uptake on PET. And ultimately it proved to be fibrous dysplasia. Point I'm making is that nuclear scans, maybe PET, maybe SPECT, maybe normal bone scan, they do come for polyostotic fibrous dysplasia, and keep your minds open for that. So, okay, now we have got another 5-minute break, and when we'll meet up, that will be the last component of so can we have number 11, please? If number 11 is with us?
Yep.
Okay. So, over to you. How will you describe this?
So this is a frontal pelvic radiograph for a 2-year-old male. The bilateral femoral epiphyses appear sort of slightly stippled in appearance with irregular margins and some loss of height on the left. There's also possibly an associated effusion on the left-hand side. No other abnormality is seen. My primary differential for these appearances would be avascular necrosis.
So
Yes,
avascular necrosis means Perthes disease. Should you consider it at 2 years of age?
Probably not.
Yeah. So what's the age for Perthes?
Older, but I can't remember off the top of my head.
Yeah, 4 to 8. So anything else comes to your mind other than Perthes?
No.
Okay, that's fine. So if you see here, this is the differential diagnosis of irregular or stippled epiphyses. Normal is a spectrum. Avascular necrosis, please remember that they can be bilateral in 10%, but the age group is different, not less than 4 to 8, 4 to 9, that's the age group. Congenital hypothyroidism or cretinism is a very important one. And you should always remember that Marcus as Mucopolysaccharidosis, this is important. There is an entity, we call it multiple epiphyseal dysplasia, which the name tells you that the epiphysis will be abnormal. Mears dysplasia is the same thing, but this one only involves femoral capital epiphysis. So the case there was actually Mears because the other epiphyses were absolutely normal, but nobody is expecting you to just say Mears on this. But for discussion, you have to know this differential. I use the word discussion cases. They are coming in FRCR more commonly these days. Discussion cases are cases in which there is a bit of what we call a discussion about the case, but there might not be a specific diagnosis. These are the kind of cases in which when the candidate comes home, they think that they have not been able to satisfy the examiner. But it's not like that, because there was no obvious, discriminator on that case. So this is a discussion type of case. This is just for your differential, I am showing you this. That in this case, epiphyses are abnormal, but other epiphyses are also abnormal. And this is a dysplasia, which is multiple epiphyseal dysplasia. Okay, over to you.
This is a frontal and lateral radiograph of the lumbar spine for an adult patient. There is a scoliosis to the left with loss of height in the L1 and L2 vertebral bodies. On the lateral projection, the vertebra demonstrate posterior vertebral body scalloping and some irregularity of the posterior elements. I think that's the main abnormality that I can see.
So what is your conclusion?
So in summary, there is posterior vertebral body scalloping and likely a secondary deformity in the alignment of the lumbar spine. My differentials for this would include a neural-based pathology such as neurofibromatosis.
Okay, so can I stop you there? So you
Yeah.
are considering neurofibromatosis because of the posterior scalloping, fine.
Yeah.
But let me give you a hint. Look at the pedicles.
So they're thinned, or flattened rather.
Something else.
Are they quite widely spaced?
So your thinking is correct, and so slight bit of fine touch is needed. Spacing is what we are talking about. Is the spacing normal or abnormal? This is the discussion.
So this.
So if you see the distance between this pedicle and this pedicle,
Yeah.
this is this pedicle and this pedicle.
Yeah, so it gets progressively narrower as opposed
Right.
to getting progressively.
So have you got your diagnosis then? Can everybody please switch off the mics, please?
Would this be in keeping with achondroplasia?
Right. So, same case. Anything comes to your mind? By the way, what did you say? I did not hear your conclusion. What did you say? Did you make a diagnosis?
I asked if this would be in keeping with achondroplasia.
Oh, yes. Okay, so you've got it. So let me tackle it. If you see in achondroplasia, what happens is the key exam finding is that the interpedicular distance normal is that as we go down from the lumbar to the lower lumbar spine or the sacral spine, the intervertebral disc, the interpedicular distance increases normally, and it is other way around in achondroplasia. That's key finding to diagnose it. It can have posterior scalloping. These are secondary degenerative changes. We know that in achondroplasia, secondary degenerative changes will occur. This per se is a very, very good exam film where what you can see is that there is a what we call a tombstone appearance of the iliac wing, and with that epiphyseal abnormalities, etc. Champagne glass pelvis is the shape. But if you look carefully, again, look at this pedicle and this pedicle, distance from this to this. And then look at the distance from here to here. Look at the distance between these two. And you can convince yourself that it is decreasing. So this kind of subtle finding, but you get your diagnosis on that. Achondroplasia. Now, posterior scalloping of vertebral bodies is an extremely important exam film. Very, very, very important. If you look at this differential diagnosis, tumors in the spinal canal is one. Tumors in the spinal canal is one. Then is neurofibromatosis, acromegaly, achondroplasia. So I just want you to remember these ones. And we will see a few examples about this. So in achondroplasia, it can happen, posterior scalloping. Okay, can you please once again take over and describe this case for us?
These are frontal and lateral radiographs of the lower thoracic and upper lumbar spine for a 19-year-old male. There is long segment spinal instrumentation through the posterior elements. There is also a scoliosis of the image portion of the spine. On the lateral radiographs, we can see posterior vertebral body scalloping with enlargement of the neural canal. and likely secondary degenerative changes to the abnormal alignment of the vertebral bodies. These appearances would be in keeping with a chronic, possibly congenital disorder.
Like what?
So,
the differential. This was the differential.
yeah, so the differentials again would include achondroplasia.
No, in your case here, you have got scoliosis. You have got
Yeah.
long segment. So this patient had scoliosis and long segment instrumentation. Then you have significant posterior scalloping at multiple levels.
Yeah.
So, and by the way, you can see the pedicles. Pedicles are not, decreasing in interpedicular distance. So, what is the conclusion then?
So this is a chronic condition.
No, okay, among these four, pick up one thing.
Could this not be neurofibromatosis?
Okay, very good. Okay, well done. Now, I'll take over. You can mute yourself now. And next, if number one is with us, I'll ask number one. But let me first of all tell you about this case. Now, neurofibromatosis is one of the very, very important cases for the exam. This is the definition of neurofibromatosis 1 and F1. And this I'm going to tackle in detail when we are considering CNS. Look at these 7 points, and this is the definition. If a patient has got 2 or more than 2 of the following, you call it an F1. The first 4, which are in white color, are not for us. The clinicians are going to tell you this. K-folia spots, axillary freckling, Lish nodules, which is iris hematomas, or first-degree relative. So these are all for what we call the clinicians to tell you. But 5, 6, and 7 is where radiology plays its role. Neurofibroma, 2 or more, or plexiform neurofibroma. So we will see all of these things when we do CNS. Optic nerve glioma. Look at this distinctive bone dysplasia. And please remember, earlier today when we did see the pseudo-arthrosis of the tibia, that is what can happen in NF1. Then there is what we call dural ectasia. Bare orbit, we will see it in CNS or head and neck module. But dural ectasia is what you were looking at. In dural ectasia, what happens is, it is apathetic dura, simple as that, which can cause posterior scalloping. And sometimes I'll show you later on these films in CNS, where, they are synonymous with the term pseudomeningoceles. There can be also laterally, they might be going lateral into the neural foramen. And you have to discriminate. Please remember that in neurofibromatosis, there can be just dural ectasia causing the posterior scalloping. And in other cases, there might be some tumor also, as in a schwannoma or a neurofibroma sitting there. So both of these can cause posterior scalloping. Okay, thank you. Is number 1 with us? If yes, then say if you can acknowledge.
Yes.
So, this is my favorite film, absolutely favorite. So, good that you got this. It's a very, very, very good film. Over to you.
Okay, so this is a frontal radiograph of the lumbar spine. Okay, so there's no scoliosis. On this frontal view, the vertebral body heights are normal. I'm just looking to see the pedicles, which I'm finding difficult to see on this AP view. Yeah, I can't see any pedicles at all. And the transverse processes are present. So in summary, this patient has clearly a congenital condition with absence of the pedicles in the lumbar spine.
Okay, so let me show you a lateral.
So on the lateral view, there is posterior scalloping of the vertebral bodies throughout the lumbar spine. As seen before, there are no pedicles. And there's some sclerosis on the posterior elements. And the spinal canal appears to be widened. So possible causes for this would include dural ectasia, and if that's the case, this could be part of neurofibromatosis type 1.
What else? Okay, what else other than dural ectasia?
So I don't know.
Okay, let me take over. So your findings are correct. Basically, if you see this AP film, what is happening? If you look at this pedicle and this pedicle, they are actually compressed, and the interpedicular distance from here to here is slightly increased. But this finding is present here, 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 here. And if you look at the lateral, look at this pedicle, you see the pedicle here, you see the pedicle here, and you don't see the pedicle. Why don't you see? Because they are thin, because of radiographic factors. They are so thin that they give you this pseudo appearance as if they are not present. With that, you see this posterior scalloping. Something is sitting inside. Something big is sitting inside. And you talked about dural ectasia, and your hypothesis is that whole of the dura is, sort of ectatic. Okay, fine. I will take that. But having said that, this is a spinal tumor. And this is another case, not the same case, because I don't have a cross-sectional imaging for the previous case, but this one tells you what happens. This is an exam case once again. This is what we call a myxopapillary ependymoma, or the phylum terminal or conus ependymoma, in which ependymomas are grade 2 tumors. They are long-standing. One of the key findings is visible here on this T2 weighted sequence, that there will be hemosiderin deposits, which is blood, chronic blood, which will be low signal on T2. But look what is happening, because it's sitting there for ages. It is doing posterior scalloping. Now look at these axials, and this will tell you what happens. It is sitting within the spinal canal, and it is causing, this. You can see that this pedicle is thinned out. So the previous case was similar example. So this is, the differential of posterior scalloping, tumor in the spinal canal. So this was a tumor in the spinal. And there is another differential in your book, which is widened interpedicular distance. Myelomeningocele is one, but intraspinal mass, diastematomyelia, these are the ones which can cause widened interpedicular distance. Yes, please.
Okay, so this is a frontal radiograph of a hand and a lateral spinal radiograph of a 2-year-old female who's short for age. So on the lateral spinal radiograph, there's an abnormality in one of the vertebral bodies within the lumbar spine. It looks like the L2 vertebral body. It's got a shortened anterior distance. Looking at the radiograph of the hand, there's an abnormality at the distal radio-ulnar joint with some erosion of the medial surface of the ulna.
What's happening to the metacarpals? Is there a pattern to that which can help?
So the metacarpals are a little bit elongated and widened. And yeah, they're just shaped a bit abnormally.
This appearance, what do you call this appearance of a vertebra? This here, this thing.
I don't know. So
right. Now, if you look here, this gives you a proximally tapered. If you see these metacarpals, you will appreciate that they are slightly more thicker here, and proximally they are tapered, right? So this is a congenital abnormality, which is again an exam abnormality, but this thing is the key which you have to pick up. So this is the pelvis of the same case. Anything comes to your mind?
so there's what diastasis of the pubic symphysis?
Not really, but you've got a point that the distance might be slightly increased, but there are so many other things happening. Can you put everything together and give me a diagnosis? If you see these femoral capital epiphyses, they look to be slightly stippled.
Yeah.
At the pelvis, it is narrow. And this pelvis, by the way, in description is known as the simian type of pelvis, ape-like pelvis. So all of this together, what is the diagnosis?
I don't know. So.
No. Okay, that's fine. Don't worry. So this is mucopolysaccharidosis. Mucopolysaccharidosis is a spectrum. There are 6 types which are described, and Morcus is type 4. And these patients are mentally normal, and at times they are diagnosed on radiology, by the way. And at times what happens is that as the baby is growing, they might look fine and they might be diagnosed after 3 or 4 years of age. So that is the only type of mucopolysaccharidosis which is important. Key findings for the exam is, the vertebrae. The vertebrae will be abnormal. They can be bullet shape, as in this one, bullet shape. And there can be beaking, anterior beaking, which can be at the inferior edge or middle portion. And there can be various other, non-specific findings. Epiphysis will be abnormal, metaphysis. The long bones can have this tubular appearance. You got it right, that there might be subluxations here. There can be simian pelvis. With that, there will be fragmentation of the epiphysis. So please remember, it will also come in the differential diagnosis of, that stippled epiphysis. You remember we did a case in which both femora had stippled epiphysis. So it will come in that list also. Another finding, this is another patient. I showed you another patient. One of the findings which is in literature is this one, that the metacarpals, they have got a the proximal ends are proximally tapered. You can imagine that this end is tapered and the distal end is flared. So this is mucopolysaccharidosis. Before we continue, we are just finishing in another 15 minutes or 10 minutes. Have we got with us number 14?
Yes, hello.
Okay, so number 14, you are next, and thank you to number 1. So I have given you the diagnosis in this case, but just as a practice, can you give me the findings? Can you describe the findings? Because this again is an exam case.
Right. On the middle image, it's a frontal projection of the lower dorsal and lumbosacral spine, and showing the upper pelvis as well. I can see that there is progressive narrowing of the interpedicular distance, particularly within the sacral vertebrae. Also, the pelvic bones are abnormally shaped. They have the characteristic tombstone appearance of the iliac bones bilaterally. On the lateral projections, I can't really see full details within the whole spine image, so I just comment on the zoomed image. There is abnormal bullet-shaped vertebrae with decreased height and shortened pedicles as well. I can't see any other abnormalities.
Excellent, well done. Good.
Thank you.
So what I wanted to show in this case, that this anterior beaking of vertebra, please remember, beaking can be in the central portion, beaking can be in the inferior portion, which was the last case. You see this beaking here,
It's inferior.
Not specific just for one thing. It can happen it can be seen in achondroplasia, it can be seen in what we call mucopolysaccharidosis. So that was the main point here.
These are CT and MRI images of the spine. Within the CT images, I can see sagittal.
So, excuse me, these are 3 different cases. So you can describe 3 different. Just confine yourself to this one, then this one, then this one.
Or I can start by the far right one because it's the obvious one.
Okay.
There is
This one.
this looks like epidural distension or neurofibromatosis, causing posterior scalloping of the lower lumbar and sacral vertebral bodies. Within the middle images, these are T2 and T1 sagittal images. I can see a well-defined intramedullary lesion causing expansion of the distal spinal cord. The cord also seems to be terminating early. It should be far downwards than this. I'm not sure if it's because of the image. The intramedullary lesion is causing focal posterior scalloping of the adjacent vertebral body. On my normal practice, I would arrange for contrast images for this lesion for better characterization, but based only on these images, my differentials would be an intramedullary neoplastic lesion. This could be an ependymoma or astrocytoma. I would also like to review the axial images just to make sure that it's an intramedullary lesion. There is another option that it would be an extramedullary intradural lesion. The far left images, the CT images show a lytic lesion within the right pedicle. It is causing bony expansion and shows a thin sclerotic margin. This is also for differential diagnosis. On the top of my differentials would be a chondroblastoma. Yeah, that's all I got.
Okay, so a bit of fine touch. Now, this is a case of dural ectasia secondary to NF1. You got all of them, you got it right, but the only thing is in the description, what I wanted to show you this and show you this in one slide. Here, this associated tumor, right? You have to mention it as a pertinent negative, that it is not associated with a mass. You remember that myxopapillary ependymoma, which I showed you, that was giving you the same appearance. And,
yes.
And this, you remember this thing?
Yes, yes. Yeah, it's almost identical.
Yeah. So in your pertinent negative, we use the word pertinent negative in the exam. You have to tell the examiner that there is nothing else. This is just CSF intensity, and this is in keeping with dural ectasia. Here's something which you brought a smile on my face at 9 o'clock, because your last sentence in the description should have been your first.
All right.
You see, why did you jump to the conclusion that this is intramedullary, right? And first thing you have to is confirm that this is intramedullary, and for that, correlation with axial is critical. You cannot make a diagnosis because a intradural extramedullary lesion might be sitting here, and this is, by the way, it is not intramedullary, it is intradural extramedullary. It is pushing the cord and giving you this pseudo appearance. So that is the learning point in this case, that you have to ask for axial in the beginning. I would like to see the axial, describe it, and then tell the examiner that I want to make sure that it is where it is. And it was this is the differential will be a schwannoma or a neurofibroma.
Yeah.
This case, again, it is similar to this case, but this is a CT scan. It is not the same case. And it is also schwannoma slash neurofibroma. Of course, you don't have evidence more than that. Okay,
Right.
Actually, this was the last case of the day.